Hello everyone, welcome to another episode of Clinical Case Discussion. This is Dr. Bharat Kumar Nandavaram. So let's continue the second episode of GOITRE. In the previous video, we have discussed basics of thyroid swelling and the basic anatomy and all. In this video, we are going to focus mainly on the history part of the thyroid swelling. Okay, right. Before we enter into the case sheet, we need to have a broad view about the approach to a neck swelling. Please understand, whenever a patient comes to you with a neck swelling, the first thing you need to understand is you need to check where the swelling is present. Means whether it is a midline neck swelling or a lateral neck swelling. Okay, so again, lateral neck swelling you will approach according to the triangles. There are different triangles of the neck. So according to the triangle of the neck, again, in that particular triangle you will decide whether it is a solid or a cystic one. And coming to midline neck swelling, this is how you can easily remember the differential diagnosis of midline neck swelling. So you need to decide whether it is a solid or cystic. Again, in solid, you can remember from top to bottom. First one is lymph node. So you have 1A, that is nothing but submental lymph node. The others are, you have got a level 6, that is nothing but pretracheal lymph node and also prelaryngeal lymph node. Right? Now, coming to the thyroid gland per se, you have either solitary thyroid nodule, then multinodular goiter, another one is diffuse goiter. Right? Now, very rarely, these are very rare, which arise from the bone. Like you can have any bony tumors arising from the mammalian sternum or even hyoid bone, very rarely. Okay. Now, coming to others are, you can have persistent thymus or you can have ectopic thyroid gland, rare again. Okay. Now, coming to the cystic swellings which are present in the midline neck. So you can again remember from top to bottom. So one is ranula. Then you have got cervical dermoid, then subhyoid bursitis. This is the hyoid bone. Just beneath or below that, you have a bursa, and if it gets swollen, you have subhyoid bursitis. Then upper midline swelling, which moves with both the protrusion of the tongue as well as with deglutition, nothing but your thyroglossal cyst. Then, whenever there is any cystic swelling present in thyroid isthmus, then suprasternal space of Burns is nothing but suprasternal space. Rarely you can get a cold abscess in that particular area. So it is nothing but suprasternal space, right? So it is called space of Burns. Then very rarely you can get an aneurysm of innominate artery, nothing but arch of aorta. Then Ludwig's angina overall. That's very common you see in ENT usually in case of immunocompromised people. So these are the examples of differential diagnosis for midline neck swelling. All right. Now let's get into the case sheet part. So the first one is patient details. Name, age, gender, occupation, address. So the first one is age. How is age important in a case of goiter? You can divide, whenever you are studying about any particular case, you can divide it into three headings. So younger age group, middle age group, then elderly. Coming to younger age group of people, I told you, even though the pathology is congenital, but the clinical manifestation will be somewhere around in second decade. So the condition is nothing but your thyroglossal cyst. Then because of the enzyme deficiency, there can be a goiter arising in younger people, that is nothing but dysharmonogenesis. And in case of puberty, few people will get goiter, that is nothing but simple goiter, nothing but physiological goiter. Then rarely you can get primary thyrotoxicosis. And when it comes to malignancies, out of the main five malignancies, you have got five important malignancies: papillary, follicular, anaplastic, medullary, and lymphoma. Out of these five, usually papillary can be seen more commonly in younger age group. Also in middle age group also it will occur. Then when it comes to medullary malignancy, it is again two types. One is familial, second one is non-familial or sporadic. So usually not only here, any familial variant of a particular disease will usually manifest at younger age group. So here also you can see familial variant of medullary thyroid carcinoma will usually occur in younger age group. Okay. Now coming to middle age group, you can have solitary thyroid nodule or you can have multinodular goiter, then colloid goiter, right? Then coming to thyroiditis, Hashimoto's is usually more commonly seen in case of middle age group. And when it comes to malignancies, One of the other differentiated thyroid cancer, nothing but follicular cancer, is more common in case of middle age group. Now coming to elderly, you can have MNG, or even rarely you can get a solitary thyroid nodule. And when it comes to malignancies, the worst prognosis among all the thyroid cancers is nothing but anaplastic carcinoma. It is more common in elderly, and non-familial variant of medullary carcinoma thyroid is more commonly seen in elderly age group again. Okay, right. So this is the importance of age in case of a goiter. Now coming to the next one. So here they'll ask little bit about goiter classification. So what are all the different types of thyroid swellings which you can have? So you can remember, one is simple goiter, then toxic goiter, neoplastic, and inflammatory. So in simple goiter again you can have the entire thyroid gland is enlarged, that is nothing but diffuse hyperplastic. The other variants are something like physiological goiter, pubertal goiter, pregnancy. Next, another form of simple goiter can be multinodular goiter, right? Coming to toxic, hyperthyroidism is of two types mainly: primary thyrotoxicosis, secondary thyrotoxicosis, and the third variant will be toxic adenoma. So it is diffuse thyroiditis, Graves' disease, and multinodular goiter, toxic adenoma. Coming to neoplastic, again you have benign and malignant. In malignant, you have again papillary, follicular, anaplastic, medullary, and lymphoma. Right? Next, coming to inflammatory, you can have autoimmune thyroiditis like chronic lymphocytic thyroiditis, which is nothing but your renal thyroiditis, or then Hashimoto thyroiditis. Then granulomatous is nothing but Degerven's thyroiditis, and fibrosing is nothing but chronic invasive fibrous disease, nothing but Riedl's. We will discuss thyroiditis in a separate slide in the subsequent slides. Next is infective. So you can have, in the setting of a acute infection, you can have acute bacterial thyroiditis or subacute viral thyroiditis. Then in chronic, you can have tuberculosis and syphilitic very rarely. And the other one is amyloid. Okay, very rarely you can get amyloid in thyroid. So these are the examples of different types of pathologies in case of thyroid swelling. Right. Next, coming to gender, the basic dictum is that usually autoimmune disorders and hormone related disorders are more common in females, whereas occupation related disorders and habits related disorders are more common in males. So here also, as thyroid gland is something like an endocrine gland, this is something related to hormonal imbalance or hormone related diseases. So obviously, usually goiter is more common in females. How much common? So female are more prone to get goiter. It is 8 is to 1. Whereas thyroid malignancy per se, it is again more common in females. It is 3 is to 1. So these are the two important points you should remember. Right? Next, coming to occupation. Occupation doesn't have much significance per se, but one important point you can remember is wherever the people are working in those areas or in those occupations with radiation exposure. So, the basic point is that in case of a prolonged radiation exposure, people can get papillary carcinoma more commonly in the long standing duration. Also, the other point you can remember is stress, any occupation with stress. Stress itself is a predisposing factor for goiter. So, these are the two important points you can remember. Another important point you need to understand is in case of radiation exposure, you can get rarely lymphoma also, but usually you will get more commonly papillary carcinoma thyroid. Then coming to address again, you need to remember the question will be something like which group of areas are more prone for goiter. So you need to understand hilly areas or coastal areas or those areas which are adjacent to those factories with radiation exposure. Again, you know the map. So here in hilly areas, you know that usually the soil contains less iodine. So you know that thyroid hormone synthesis, for the thyroid hormone synthesis to occur, iodine is very essential. So in hilly areas, usually there will be less content of iodine. So they will get iodine deficiency goiter. Okay, right. Next, coming to the chief complaints, whenever a patient is having goiter, what are the main complaints with which the patient can come to you with? Obviously, the first complaint will be swelling in front of neck. Swelling in the front of neck. The other one is there may or may not be pain in the swelling. Okay, so these are the usual complaints. We will see, we will expand how the history of present tense will go in case of goiter. Okay, so I told you history of present tense has got three main headings. So one is history related to the presenting complaint in the system involved. Second one is complications history. Third one is etiology history. These are the three main headings in case of history of present tense in any case. We will apply the same thing to our goiter. So don't be afraid to, by looking at this table, we will again just divide the components and we will look at each one. I told you the chief complaints will be swelling and pain. So whenever a patient is coming to you with swelling, the basic headings with which you should expand the history of present illness is duration, site, mode of onset, progression and regression, associated complaints. And in again in associated complaints, pain is one of the important complaints. And I told you in the video of introduction to case sheet writing, whenever a patient presents to you with pain, you need to describe it under the heading of Socrates. In case of goiter, what are the main important things that we should remember regarding pain is that whether the pain plus swelling appeared at a time, so it will suggest most of the time it will be something like a thyroiditis. Or if it is something like a patient has got a long standing goiter, let's say for example patient has got multiple nodules, and suddenly the patient developed a pricking type of pain at one side. So one of the complications of multinodular goiter is hemorrhage into the nodule. So in such scenario you can get sudden onset pricking type of pain. Now patient is having long standing goiter, and patient developed a dull aching long standing pain, it may suggest you malignancy. So these are the points related to pain and the consequences. Okay, right now coming to the second subheading of the history of present illness in goiter, that is nothing but complications history. To understand the complications history, we need to remember this particular diagram. So before we move there, one question the examiner can ask you whenever you say pain in the swelling is painful thyroid swelling, nothing but painful goiters. So you can remember them again: inflammatory, traumatic, neoplastic, and others. So in the others, I told you just now, hemorrhage into the nodule is one of the important conditions. Then when there is a huge goiter because of the stretch of the thyroid capsule, that is nothing but pretracheal fascia. In such scenario, you can get, there will be discomfort or little bit pain will be there. Okay. Now coming to inflammatory swellings, you know it is nothing but thyroiditis. So thyroiditis will be very painful. The other one is very rarely you can get thyroid abscess in case of immunocompromised people. Now coming to trauma, rarely you can get a hematoma after this trauma. Then this is one common scenario where you can get pain in the goiter. That is nothing but post FNAC. Right now coming to neoplastic, usually neoplastic is something like one scenario which is painless. But in case of anaplastic carcinoma, there may be pain, or any malignancy with the nerve infiltration, then you can have pain. So these are the common scenarios where you can have painful goiter, right? Now, so I told you the second subheading of history of present illness is history of complications. To understand the history of complication, I told you in the first video, you must always remember this diagram. The entire complications history will revolve around this particular diagram. We will see how. So in complications history, the first thing you should understand is pressure symptoms. Pressure symptoms. So what are the important pressure symptoms we should ask? First one is history of difficulty in breathing, nothing but shortness of breath. Why? You know, here you can see in the axial section, this is the thyroid gland you have. Just behind the thyroid gland, you have got trachea. So this is trachea. Whenever there is a long-standing goiter, there can be pressure atrophy of the tracheal cartilages. This trachea can get little bit weakened and it can become scabbard trachea. So there will be usually compression of the trachea that can cause difficulty in breathing. The other point you need to understand is, second point is difficulty in swallowing. Why? Again, you need to look at the diagram. Behind the trachea, you have got esophagus. So usually this difficulty in swallowing will be, rather than the compression, it will be because of the infiltration. Infiltration is a different term from the compression. Why? Because esophagus is something like a muscular tube. Here, one common controversial question the examiners can ask you is which occurs first, whether it is difficulty in breathing or difficulty in swallowing that will appear first. There are two schools of thoughts. First one is Trachea is something like a cartilaginous structure, so it will not allow the compression that easily. That is why difficulty in swallowing occurs first. The contrary people, like the second school of thought, is usually esophagus is a muscular organ. That is why it will not allow the infiltration to occur that easily. So dysphagia occurs later. Okay. So again, depending upon scenario, you can go with your answer. Right. Now coming to third one is your recent change in voice. It is more of a hoarseness of voice. So why are you asking about hoarseness of the voice? Again, you can look at the diagram here. This is the trachea and this is the esophagus. In the tracheoesophageal groove, you have got one important nerve, nothing but recurrent laryngeal nerve. So whenever there is infiltration, again you need to understand it is not because of compression, it is because of infiltration of the malignancy. So because of the infiltration into the recurrent laryngeal, you can have hoarseness of the voice, right? Next, this is regarding pressure symptoms. Second one is, I told you thyroid is a functional like endocrine gland. So it has thyroid hormone secretion. Whenever this hormonal levels increase, it will cause hyperthyroidism. Whenever it decreases, it will cause hypothyroidism. So it is nothing but functional disturbance. That is the second complication history we should ask. So functional disturbance. What are the functional disturbances you are asking about? One is there any history suggestive of hypothyroidism or hyperthyroidism? The moment you say no history suggestive of hypothyroidism or hyperthyroidism, the examiner will stop you there and he will ask you what are the history points you have asked about hypothyroidism or hyperthyroidism. Okay. Now to understand that, we need to look at this table. Okay. So one is only symptoms we are looking. This is most important table you should remember and understand. So we are looking at the only symptoms first. So you can remember from top to bottom again. So the first one is lethargy or sluggishness. Thyroid hormone is very essential to be active. So whenever there is hypothyroidism, patient will be very lethargic. And in case of face and the eyes, there will be facial puffiness, which is something like a sign, not a symptom basically. So, and when it comes to tongue, you can ask about difficulty in talking. Why? You know, in hypothyroidism, there will be edema everywhere. So here also you can have one is glossomegaly will be there, and also there will be little bit vocal cord edema also. Because of that, there will be difficulty in talking. Okay, right. Next, coming to GIT. So there is obviously in neck you can have goiter. Apart from that, in GIT, in CVS it is more of a in hypothyroidism, bradycardia will be there, but that is a sign. So that is a sign here. Now, coming to GAT, please understand thyroid hormone is very essential for the normal peristalsis. Whenever there is hypothyroidism, there will be decreased peristalsis that will cause constipation. Okay. Now, please understand genitourinary system and thyroid hormone level has got inverse relation. What do you mean by that? I'll just explain the concept. Please understand, in hypothyroidism, there will be menorrhagia or polymenorrhea. And in case of hyperthyroidism, there will be amenorrhea or oligomenorrhea. Why is it so? So please understand the concept. Normally, if you take this is your thyroid gland, from the anterior pituitary, TSH comes. And then this TSH goes and it will act on thyroid gland to release T3 and T4. Now this will go and give inhibit negative feedback that will cause TSH to decrease. So now in case of hypothyroidism, what happens in hypothyroidism? Because in hypothyroidism there is decrease in T3, T4, it will give negative feedback. That is why there will be increased TSH, right? Along with the TSH from the anterior pituitary, you also have got increased FSH. So the bottom line you should understand is, I'm writing the line here, FSH and TSH have common alpha chain. This is the bottom line you should understand. What do you mean by that? So the structure of FSH and TSH has got a common alpha chain. So that is why whenever there is increase in TSH, there is FSH is also increasing. So this is the alpha chain. So both have common alpha chain. That is why whenever there is decreased T3, T4, nothing but hypothyroidism, there will be increased TSH. Because of the increased TSH, obviously there will be increased FSH. So this increased FSH will cause menorrhagia or polymenorrhea. Now, you can apply the same thing to hyperthyroidism. So, what is happening in hyperthyroidism? There will be increased T3, T4. So, because of the increase in T3, T4, it will give negative feedback, and so TSH will be decreased. Along with TSH, FSH is also decreasing. That is why there will be oligomenorrhea or amenorrhea, right? This is the concept you should understand, and this is one important line we have to remember. FSH and TSH have got common alpha chain, right? Now, coming to limbs, usually there will be history suggestive of proximal muscle weakness. There will be proximal myopathy. Okay, right. And coming to general, there will be usually in case of hypothyroidism, there will be dry and inelastic skin. That will be a more of a sign. Now coming to hyperthyroidism. Okay, so coming to hyperthyroidism, what are the important symptoms? Again, you can remember from top to bottom. So in hypothyroidism, patient is very lethargic and sluggish. Here you have got opposite, very anxious, very restless, and there will be insomnia, right? Now, coming to face and eyes, in very chronic hyperthyroidism, there will be thyroid ophthalmopathy, and patient can have exposure keratitis, and patient may have watering of eyes. Rarely, very advanced case, right? Now, the other one you need to understand is stammering of voice because of the again tremors, tongue tremors. So to identify the what is the history part of tongue tremors means stammering of the voice, and there can be when it comes to CVS there will be palpitations because of the increased heart rate. And just now we have discussed about genitourinary effect of thyroid hormone, so it will be opposite. In hyperthyroidism there will be hypomenorrhea, that is like the amenorrhea or oligomenorrhea. Now, when it comes to limbs, there will be shivering of the hand. So you can ask about how will you ask history of hand tremors means you can ask about shivering of the hands. If the patient is literate, you can ask about change in handwriting. This is another important point. And you can ask for hand tremors history. You can ask whether there is any shivering of hands when you try to thread a needle or when you try to do certain things like that. Okay. So this is the symptoms of hyperthyroidism. So in history, you will tell a single sentence if there is nothing suggestive of hypo or hyper. That is no history suggestive of hypothyroidism or hyperthyroidism. Then when the examiner asks you what are the history suggestive of hypo or hyper, you need to tell these things in order, right? Now, coming to third one, that is nothing but history suggestive of malignancy. Again, what will you ask history suggestive of malignancy? One is recent rapid increase in size that we will be discussing in swelling per se, and also history of loss of weight and loss of appetite. Loss of appetite and loss of weight, right? Now, when you suspect there is a malignancy, means there is a short duration, recent rapid increase in is there, history of loss of weight and loss of appetite are present, then only you will go for history suggestive of metastasis. And again in metastasis, I told you CNS, then respiratory system, musculoskeletal, then GAT. So top to bottom you will remember. Please go and watch Introduction to Case Sheet Writing. What are all the things you should ask to know about history suggestive of metastasis? Okay. So this is the second subheading of history of present illness. That is nothing but history of complications. Now the third heading, that is nothing but history of etiology. We will discuss about etiological history subsequently in each heading of the case sheet, right? And please understand what are the causes of shortness of breath in goiter. You can have three important causes. Just now I told you it is because of the compression of trachea. The other two causes, very rarely in advanced cases, is that it can be metastasis. So when the metastasis go to lung, then there can be uh, before metastasis. You can understand. Second one is it is because of the hyperthyroidism. Why? In hyperthyroidism, it can go into CVS and it will cause high output cardiac out failure. High output cardiac failure. So, in case of cardiac failure, also there will be shortness of breath. This is the second reason. Third one is metastasis. So, first one is compression, second one is hyperthyroidism, third one is metastasis. This much depth usually will be asked for PGs rather than the UGs. Okay. So, metastasis to lung, or usually this lung again you can divide it into something like a pleural metastasis and a parenchymal metastasis. So in case of parenchymal metastasis, there will be more of a something like a uh, hemoptysis, chest pain, etc. Whereas in case of pleural metastasis, there will be SOB, cough. These are the basic symptomatology, right? So these are the causes of shortness of breath in goiter. Now, coming to Horner syndrome, it is one important complication. Again, if you look at this diagram, so if there is malignancy in thyroid gland and it is extending posterolaterally like this, please look at the, just remember the anatomical structures, you can understand the complications. So this malignancy can go and infiltrate the carotid sheath, and it will infiltrate the common carotid artery or internal carotid artery. In such case, very rarely, if the opposite side carotid is also not good, you can have history of syncopal attacks, but it is very rare. And the next one anatomical structure you need to understand is sympathetic trunk. So whenever there is malignancy which is going and infiltrating the sympathetic trunk, that will result in a syndrome called Horner syndrome. So what is the main pathology of Horner syndrome? It is the damage to the cervical sympathetic chain which is supplying to the head and neck. So what are the important features of Horner syndrome? You can remember with the help of a mnemonic: high sample. So H for heterochromia iridis. So I told you it is because of the damage to sympathetic supply, sympathetic chain. So H for heterochromia iridis. Nothing but both iri will be in different colors. It is more commonly seen in congenital Horner syndrome. S for sympathetic chain damage. I for inferior eyelid eversion. Why? Because of the paralysis of inferior tarsal muscle. Inferior tarsal muscle palsy. Okay. Now, next is S for sympathetic chain damage. A for anhydrosis. An means absence. Hydrosis means sweating. So, absence of sweating on the affected side. That is called anhydrosis. M for meiosis. Normally, sympathetic chain has got pupillary dilatation effect. But in Horner syndrome, sympathetic chain supply is gone. That is why there will be opposite action. So, nothing but pupillary constriction. That is called meiosis. Next one is partial ptosis. I'll explain why there is partial ptosis, why not complete ptosis. Then L is loss of ciliospinal reflex. E for anophthalmos, relative anophthalmos. Now we will discuss more about partial ptosis and loss of ciliospinal reflex. So please understand, why is there partial ptosis, why not complete ptosis. You know, basically for you to elevate your upper eyelid, normally this upper eyelid is having this levator palpebrae superioris muscle is there now. It has got two important components. One is voluntary component. Second one is involuntary component. So this involuntary component of LPS is called Muller's muscle, which is supplied by this sympathetic chain. Whereas this voluntary part of the LPS is supplied by cranial nerve 3, nothing but oculomotor. In case of Horner syndrome, only Muller's muscle is gone, but the voluntary component of levator palpebrae superioris is intact. That is why there will be only partial doses here. You can see here, only partial doses will be there in Horner syndrome. Okay. So next, what is loss of ciliospinal reflex? Please understand, when you are examining in a patient, you will pinch at the nape of the neck. This is a sympathetic stimulus. In normal patient, whenever there is sympathetic stimulus, there should be ipsilateral pupillary dilatation. But in case of Horner syndrome, this ipsilateral pupillary dilatation will not be there. That is called loss of celospinal reflex. What is celospinal reflex? When someone pinches at the nape of the neck, there will be ipsilateral pupillary dilatation. That is called celospinal reflex. That will be lost in case of Horner syndrome, right?